DU. I, Dr. Priya Kedas, Assistant Professor, Department of Biochemistry, wish you all a pleasant morning and happy Doctor's Day. IQAC, Internal Quality Assurance Cell, aims at achieving quality through continuous improvement with cooperation of all stakeholders. With this motto, the IQAC of VMRF DU is organizing a series of webinars to develop a system for conscious, consistent, and catalytic action to improve the academic and administrative performance of the institution. We, from Vinayaka Mission's Kribananda Warrior Medical College, Salem, are happy to organize the 27th Quality Webinar Series on the topic Role of Extension and Outreach Activities to Improve the Healthcare in Teaching Hospitals. Now I invite Dr. Manivannan, Professor and HOD, Department of Pharmacology and Criteria 3 Head, to welcome the gathering.
Good morning, Dr. Priya. Respected web members, I welcome respected Dean, Professor K. Vendan sir, Professor Nanashekar, Director IQSC, Medical Superintendent Dr. S. R. Rangabhashan sir, Deputy Dean, Professor Dr. Deepthi Shastri, Director, Hospital Development Committee and DMS, Professor Dr. E.M.J. Karthikeyan sir, IQSC Coordinator of our college, Dr. D. Selvam, the guest speaker of the day, Professor S. Dr. Ashwati, Professor in Community Medicine, AIMS Kochi, HODs, faculty of various departments, good morning all. On behalf of IQSC, Vinayaka Mission's Kribananda Warrior Medical College and Hospital, Salem, pleased to welcome you all for the IQSC virtual webinar on role of extension and outreach activities to improve the healthcare in teaching hospitals. We thank the speaker for accepting our invitation to share her knowledge on the topic. Welcome you, ma'am.
Thank you, sir. Now I request our most respected Deputy Dean, Ma'am, Professor Dr. Deepthi Shastri, to address the gathering.
Respected Director, IQAC, Vinayaka Mission's Research Foundation, deemed to be University, Dr. P. Nanashekar. Respected Director, Hospital Development Committee, Dr. E.M.J. Karthikeyan. Respected guest speaker of the day, Dr. Ashwati S., Professor of Community Medicine at Amrita Institute of Medical Sciences, Kochi. Respected Coordinator of IQAC, Dr. V. Selvam. Respected members of IQAC of the institution, heads of departments, and my dear faculty members, good morning. Amrita Institute of Medical Sciences is very well known for its active engagement in outreach and extension activities, which address the healthcare needs of the local community, provide medical education, and also enhance the community awareness. And one of their key initiatives, which I am aware of, is the mobile telemedicine unit that travels to the remote and rural areas to provide healthcare services. And I am given to understand that this particular initiative has improved the access to quality healthcare by the unserved population of Kerala. The other impressive initiative of AIMS that I've heard of is their active involvement in disaster management and response activities in times of crisis like flood and pandemic. And these kind of initiatives of AIMS have demonstrated their commitment to improving public health and also creating a positive impact in society. I'm sure our eminent guest speaker, Dr. Ashwati S., who is a leading contributor to such initiatives in Amrita Institute of Medical Sciences, will share her rich experience with us, which will help us to build the activities that we already have in place in our institution. Here's wishing the organizers, the IQAC, all the best for the successful outcome of this program. Looking forward to your insightful talk, Dr. Ashwati ma'am. Thank you.
Thank you, ma'am. Now, I humbly request our respected Director IQAC, Professor Dr. Gnanashekharan, to address the audience.
Very good morning to all of you. It's a pleasure to be before all of you on this Doctor's Day, and it's coincident that this webinar, which falls on a Doctor's Day, is being hosted by the Medical College of the university, and the resource person is also a doctor, and seeing the participants also, I see that most of the participants today are doctors. So it's really a wonderful occasion. I first wish all the doctors a wonderful Doctor's Day. And looking at the topic, role of extension and outreach, every institution, involves in extension and outreach activities throughout the year. Through NSS, NCC, or other organizations they have. But the main problem is we don't record these activities properly. If you look at the medical institutions, extension and outreach is part of their curriculum. And specifically, the community medicine department is one which is in charge of organizing such events. If you look at the definition given by NAC for extension, it says extension is something which is part of the curriculum, which gives an emphasis on neighborhood services, what service we impart to the neighborhood, which has to be integrated in the curriculum as extended opportunity and intend to help, serve, reflect, and learn. And this curriculum extension interface has educational values, especially in rural India. So this is the definition given by NAC for extension. If you look at outreach, outreach is something which we confuse with other activities. Outreach is something which we practice in creating awareness among the public by having community interaction. This is what is the definition given by NAC. So the main difference between the two is one is part of the curriculum and the other could be outside the curriculum. And how we record it is where we score our marks in NAC. This is where most of us lose. All institutions do plenty of activities, both in extension and outreach. But where we lose is properly recording it the right way and in the right place. So I think such webinars will open huge Pandora box where people will know what to do in terms of extension and what to do in terms of outreach and how to properly record it. So in that way, we have the right person today, Dr. Ashwati, that too from one of the top institutions which heads the NAC table, and that too from the community medicine department, which is really taking care of these activities. So I do hope we carry home today a good message and wonderful information, which will help in improving our community services. I wish the webinar all the best, and all the participants stay tuned and have a wonderful day. Thank you.
Thank you, sir. Our Dean, Medical Superintendent, and Director, Hospital Development Committee has conveyed their wishes for the success of this program. Now I call upon Dr. Senthil Kumar, Associate Professor, Department of Biochemistry, and Member Criteria 3, to introduce the speaker of the session.
Thank you, Priya ma'am. It's indeed my pleasure to introduce today's speaker, Professor Dr. Ashwati S. Madam currently serving as Professor of Community Medicine, Amrita Institute of Medical Sciences, Kochi, Kerala. Ma'am's qualification includes MBBS graduated from Government Stanley Medical College, followed by MD in Social and Preventive Medicine from Government VSS Institute of Medical Sciences, Sambalpur, Odisha. To add on, postgraduate diploma in adolescent pediatrics. Madam has a vast teaching experience, started her career as senior lecturer, assistant professor, associate professor, and formerly served as professor and head of community medicine, Government Medical College, Palakkad, Kerala. To add on credit, Madam has received many prestigious awards, which includes fellowship by Northwestern Feinberg Institute, Chicago, visiting scholar Bernard Lawn Fellow in Cardiovascular Health of Harvard, T.H. Chan School of Public Health, Boston, emerging leader of the World Heart Federation, as Asian Collaboration for Excellence in Non-Communicable Diseases, sponsored by Bogatti International. Ashwati ma'am's recognition also includes, she's a nodal person in developing a curriculum and for the residential training of Amrita Serve volunteers from Bihar, Uttarakhand, Madhya Pradesh. She is also a resource person for training college students, community health workers, as well private medical practitioners on Japanese encephalitis and dengue. And associate project director from Koloncherry, funded by Christopher Blinden Mission, Germany. Madam's honors include expert reviewer of extramural research funds of ICMR, reviewer of many national and international journals, members of the advisory group on Kerala Health Observatory Study, chairperson for the PhD Opens Defense Examination of Kerala University, as well honorary editor of research and reports in tropical medicine published by Dove Express Newsline. Ashwati ma'am was also an expert in research too. To mention few of her research here, she has got extramural funded nearly 4 crores received from ICMR, WHO, and other international agencies. Principal investigators of 2 clinical trials, one on effects of yoga with diabetes mellitus, and the other tobacco smoke-free home interventions. And also, Madam has published a total of 58 research papers in various international journals and attended various national and international conferences, presented papers in various countries, such as USA, Asian countries, Indonesia, Sri Lanka, Singapore, and Malaysia.
Thank you, Dr. Senthil.
Thank you, ma'am. Thank you, Priya ma'am.
Thank you, Dr. Senthil. Now I invite the speaker, Dr. Ashwati, Professor of Community Medicine, Amrita Institute of Medical Sciences, Kochi, to take over the session.
Thank you. Thank you very much, respected Dean, Deputy Dean, and the IQSC Coordinator of Vinayaka Mission Kripananda Warrior Medical College Hospital and the Vinayaka Mission Research Foundation. This is indeed a proud privilege to be here today to discuss on the role of extension and outreach activities to improve healthcare in teaching hospitals. And I also wish all the doctors present here a very warm and good Doctors' Day and many more years ahead. So I start with this. All of us would have heard of the author, the mythologist and writer called Devdutt Patnaik, who's written a lot on, who's written many books on how to be a good leader, on an Indian approach to management. And I thought the premise of this book was very interesting because what is said about the book is that at the heart of the book is a compelling premise. If we believe that wealth needs to be chased, the workplace becomes a ranabhumi, a battleground. So this is as far as the corporate sector is concerned, but I think it's equally applicable to the healthcare sector as well, with all the stresses that we take, that we assimilate over the days and over the years, and also with violence against hospital personnel and healthcare personnel in large. So it does become a ranabhumi, a battleground. But on the other hand, if we believe that wealth has to be attracted, then workplace becomes a rangabhumi, a playground where everyone is happy. I think happiness is a goal towards which all of us, healthcare professionals or otherwise, are striving to attain. And in this context, I also remember an article which I read in our newspapers a long time back, that our commitment to knowledge, our genuineness in acquiring knowledge and implementing that knowledge for the welfare of the society will help us in getting Lakshmi. That is only through Saraswati, only through, that is a means to the end is as important as the end itself, could be another way of putting it. Having said that, the dean and the deputy dean, they gave a very good definition of what outreach and extension are. So the outline of my presentation will be like this. This is largely based on our experience and is by no means exhaustive. It's just a snapshot of what we have done and what we learned and how we learned from the others and how others can learn from us as we learn from the others. So it is always a symbiotic relationship with a supplementary, complementary, and all those other things like a jigsaw puzzle, it finally fits in, like Legos, it finally fits in to form a nice pattern. So the outline of my presentation is like this. COVID taught us a lot. So what did we learn from that? Though it was a challenge, it was also an opportunity for healthcare professionals to work together, not just healthcare professionals, to work with the community together. Then what relevant projects have we undertaken to tackle health issues? The funding agencies that are available. As a deemed to be university, I'm sure you have also undertaken a lot of research. So maybe we can learn from each other in this. And as Madam mentioned about disaster management, we have played an active role in disaster management in the Kerala floods of 2018, the Kashmir earthquake, because we have a good telemedicine van with telemedicine services provided by ISRO. So we are able to undertake disaster management as well. And capacity building and research, again, very important, because as a teaching institution, our greatest strength are our students. So capacity building and research is an inevitable and a vital part of any teaching institution, and the learnings from that and the way forward. So when I thought about the different extension and outreach activities that we do, I thought the objectives would be to create a connect with the communities, to provide service to a larger number of people than the people who come to our doorstep seeking care, because again, healthcare seeking can be affected by a lot of other factors. So providing service to a larger number of people is important, and implementing various regulatory requirements of council, such as the National Medical Commission, for students to reflect and learn, and for teachers to learn through them, with them, and to develop a clientele who can rely on us to get good healthcare. And in the initial years of any new hospital, it also helps, these outreach activities and extension activities help the community to be familiar with the name of the hospital, the services provided by them, etc. So coming to the first point, that is COVID and pandemic response, how we saw opportunities in the threat. So we had our postgraduate students, MD residents undertaking telehealth activities, again, not alone, in association with the Indian Medical Association. So here they are providing telehealth because there was a lot of fear and stigma associated with COVID in the initial days. And here they are again preparing short videos, which were then recorded in YouTube, and also in association with the Kerala Institute of Local Administration, which is a premier agency to train local self-government and other bodies. So in association with them, we we made 1 to 2 minute videos on how to wear a mask properly, how to use the pulse oximeter, etc. We also trained our own healthcare workers on the use of PPE and the use of other personal protective measures against COVID. Again, there were a lot of opportunities in terms of funding. So we were able to carry out 2 WHO Unity studies. One assess the household transmission. That is, we try to estimate the incubation period, the secondary attack rate, the serial time, the generation time, and all this through the household transmission, where we would initially get the list of persons who were RT-PCR positive, and then see over a period of 30 days how many of the household members got infected. And this is the team from WHO and us. And then we had another study on case control study among healthcare workers to see what are the factors that lead to healthcare workers developing COVID. So again, as part of this, in collaboration with the District Health Administration, we reached out to people because doing RT-PCR and all was a difficulty at that time. And therefore, we were able to do RT-PCRs on 1, 7, 14, and 28 days. So we did that for the people. So therefore, the PHC, the Primary Health Center, and the people were also were very grateful to us because we used to go to their homes and do it, following good clinical practices. So this is the staff of the project going to an island not very far from here. Then in our institution, COVID vaccination commenced on January 19th, and about 1 lakh beneficiaries, while the government with its infrastructure across the state, they were providing vaccination, but we kind of supplemented and complemented their activities because we were able to give vaccination for a very large number of people. More than 1 lakh persons were vaccinated. And as people were struggling to get vaccinated, to get a slot for vaccination, we were able to provide this upfront and with a very short waiting period. We also tied up with Residents Association. We also had conducted mobile camps, and this was all, of course, under the watchful eyes of the District Health Administration. So we used to vaccinate about 3,000 people per day, whereas a PHC in a government hospital would probably only vaccinate 100, not more than 100 or 150 per day. So that was our contribution to COVID vaccination. And apart from this, there were COVID lines for the people who would be discharged from the hospital, and telemedicine. Also, we established a system of telemedicine and online training modules. Small 1 to 2 minute modules were developed. There were also live Facebook live interactions using social media. And we also used audio clips for specialized groups such as lottery workers, lottery workers, some disabled people, and all sell a lottery, and that was a way of living. And COVID threw all of this into disarray. So therefore, we were able to help the lottery workers what all precautions they should take before they go out to sell the lottery and continue with their livelihood. So we prepared these audio clips, and of course, ambulance services. This we did, of course, in tandem with the district administration, where our students were also part of the COVID control room. So not only the WHO Unity study, we also carried out ICMR funded multi-centric study to evaluate with whether BCG vaccine is effective in reducing morbidity and mortality. And we also had other ICMR studies. This is by no means exhaustive. ICMR studies on evaluating the effectiveness of Covaxin and Covishield on persons with severe COVID. And here we have our former head of the department, Dr. K. Vijay Kumar, a public health luminary, sharing the Kerala experience with the University of British Columbia on because at that time Kerala was hailed as a model, though later on with the second wave, we had a lot of Omicron cases and the cases refused to decrease, but initially, at least for the first 1.5 years, Kerala was considered as a model because of all the steps that it took. So this is again a continuation of the same at the household level, taking the RT-PCR. And this is a WHO team who came to for monitoring and surveillance to ensure quality. So quality being the continuous, it's a process of continuous improvement. So, so they were here to check on, because doing it in the household was indeed very challenging. With the PPE for the lab technician to take the PCR to draw blood, it was indeed a very challenging process. And in this, we also had taken feces and urine samples of the RT-PCR positive patients and of the COVID cases, that is. And in fact, we are probably one of the few institutions to isolate the virus, to identify the virus from urine as well. We had 3 sites for the household transmission, ourselves and Trivandrum Medical College and the Kollam Medical College. So the Trivandrum Medical College was able to identify the virus from urine. So fecal identification, of course, happened, it was present more commonly. Then again, this is from a paper that we published, the tertiary care system response in a private setup, on what we did, how the pandemic evolved, and how we changed according to. So first we looked for epidemiological history of travel outside, and then it became universal COVID screening for inpatients and bystanders as the number of cases increased. Again, continuing with that, so again, it was the community medicine department which set up the screening protocol for stratifying risk. We stratified people into high risk and low risk. So there were these centers outside the hospital where we did the screening, and then patients were referred accordingly. So apart from COVID, we have also undertaken several other projects to tackle health issues faced by the local populace. So India has advanced a lot. We are sending rockets to space, but we are unable to tackle a lot of health issues that we face on a day-to-day basis. I think as universities and as institutions which train students for taking care of the people in the future, it is important for us to understand what the local health issues are and to find solutions, because the solutions have to come from here, from us as academicians. So here is an example of some things that we did. So lymphatic filariasis, there are the 11 districts used to undertake mass drug administration, but now most of those have a very low incidence of filariasis, but the morbidities remain. Particularly a district called Alappuzha, where one of our very senior professors, who's an emeritus professor, Dr. K.N. Panikar, who has worked extensively on filariasis. So having such people is an asset to our organization, to our department, where each person has his or her strength and we build to their strength. So sir has undertaken the management of morbidity, lymphatic filariasis morbidity. And though transmission assessment survey is less than 1%, we still have people like this who are finding it difficult to live, because filariasis with its lymphedema affects the quality of life and affects their life in general. So he has prepared these shoes which can help them. He has helped design these shoes which will help them to manage lymphatic filariasis. And not only that, looking for funding, not just from official agencies, but then again, building capacity in terms of financial resources. This is Mr. Chittilapalli, who is the owner of a company called VGuard and a big philanthropist who a lot of people across the world would have heard of. And he in fact had donated his kidney to a needy patient. So he has, as part of corporate social responsibility, he has donated some money, has funded this program of vocational rehabilitation. And we have our medical director, who leads us, who supports us, who guides us in conducting all these activities. So this is again, as part of vocational rehabilitation, they were provided goats and calves in all. Then coming to the non-communicable diseases, again, a huge problem in Kerala. Kerala is the capital of diabetes. So we initiated this project. Again, we were not alone. We cannot do anything alone. So we worked together with the Alliance International, who funded us, and with the National Health Mission, which helped in the delivery of these services at the grassroots level. So we screened for diabetes-related complications among adults with type 2 diabetes. And the services include HbA1c point of care testing with HemoQ, screening for diabetic retinopathy using a non-mydriatic fundus camera, Doppler testing for peripheral arterial disease, biothiometry for peripheral neuropathy, ECG to identify coronary artery disease, and UACR, or the urine albumin creatinine ratio, to screen for changes in the kidney. Again, I'm also happy to say that these two were done as part of MD thesis project. So we can build the thesis projects into these projects, which will help us to expand the ambit of the service that we provide to the people. So these are some pictures from that. The eye examination being done, the foot examination being done, the blood examination being done. So there's a registration area initially using this HemoQ device. We measured their HbA1c, then the foot examination with the biothiometer and the Doppler to find out peripheral arterial disease, and the eye examination. And these were some of the prevalences that we found. And again, this could be higher because we were working through the National Health Mission, and therefore through the primary health centers and through the local self-government, which made it very, very acceptable. And the PHC medical officers made it a point to refer the most needy patients to us. So remember, that is the reason why we got quite high levels of these complications. Then another landmark, another flagship program is the Kochi intervention for tobacco smoke-free homes. So here we are trying to create homes that are tobacco smoke-free. That is, we are trying to bring down smoking within the homes. And we are looking for sustainable solution, a low-cost sustainable solution. So we are using, we are doing that with the help of women's self-help groups. We are training them to help us reduce indoor smoking. And how do we measure whether we are successful or not? We measure the urine potassium levels of the family members, particularly the wife and child. The child particularly because so that we could use it as an advocacy tool to tell the father that because you're smoking, you see your child is also having cotinine, and the metabolite of nicotine in the urine. And along with that, we also do indoor air quality monitoring, and it is primarily an educational intervention provided by the women self-help groups. So this is a COPD-6 device that we use, which is a portable device and gives a fair estimate of FEV1 by FEV6. And this is the air quality monitor that we are using. So this is our mayor leading us in these efforts. So this is largely based in the study is largely in the urban areas. Then yoga was something that we started long back, maybe 10, 15 years back, maybe 10 years back. And this was a study which came from that, using yoga and peer support to control blood sugar. And again, our health issues may be different from the health issues in Tamil Nadu. So the large number of elderly are a big health issue, and the percentage of elderly has gone up to 16% in our state. So here is an example of how we collaborated with the local self-government officials to transform Alapad into an age-friendly panchayat. Again, this is something that probably developed countries would think of developing a personalized healthcare plan for each elderly in the village. And of course, here we are led by people like Dr. Vijay Kumar again, and the panchayat president is right here, the panchayat secretary, and also a former IAS who was working with the local self-governments before. So these are some of the examples of how we have tried to work locally and try to generate local solutions. So then what we do is we work with the local self-government, and we help the local self-government in terms of developing program implementation plans, so that when they budget for the next year, they can budget all these things. If the panchayat perceives it as a need, it can be budgeted, so that in this particular initiative, we considered retrofitting of homes, where homes could be fitted with the toilets which are more friendly for the elderly, not the squatting ones, but the Western, the commode and all, and also with hand railings. So these were some of the projects that were submitted. And also providing walking sticks, hearing aids to the elderly. Then this has been taken forward further in the sense that elderly have now been grouped into, this is again models that are trying to be built, that we are trying to build in certain panchayats. That is, elderly who are totally alone, they may need daycare. But elderly who are alone maybe for the period when their children go to work, then they can be taken to daycare homes for recreation. And other elderly who have their family members around them, they can spend 2 or 3 hours with the other elderly in elderly groups. So it has been kind of stratified according to their need now. So that experiment is also on. In capacity building and research, we have a student community with us. They are young. We have their aspirations, which we can mold to develop it effectively. So this is an annual event that we conduct every year. This is a picture from the 2019 Amrita International Public Health Conference, which provides a platform for researchers from all fields to come and present their research, their findings, etc. So these researchers could be from the clinical departments, because everybody can practice public health. A clinician or a Ayurveda doctor or a homeopathic provider goes through the scientific steps of research. And so we have each year we collaborate with an international university. On 19, we collaborated with Harvard, and we had about 400 to 500 registrations and about 250 paper presentations. So this is one event that we do every year. And this year too, we will be doing it in December. So apart from providing an opportunity to the budding researchers, this is also a platform for speakers from well-known authorities in their subject to tell us what they have done in this field, tell us things that are the latest, so that we can learn about it and also do it in our own places. And here are our students visiting a village in Orissa. Again, a village habit, where it is the tribal population which is more. And this is part of the Amrita Serve initiative, which has our chancellor has adopted 101 villages across the country. And there we are trying to improve healthcare. And here is our MPH student working with a woman or undertaking research on a woman working in the brick film factory or working in the construction sector and looking at their respiratory morbidity. So capacity building happens in all these ways. In disaster management, as Madam Dr. Priya, I think, mentioned before, disaster management is again the whole institutions. We have our camp manager who is a very active person. So our MD students were part of the Kerala floods, and we help in establishing healthcare centers, providing medical aid, and traveling to remote areas through the flooded. We were, of course, supported by the Navy, supported by them. We were able to reach the remote areas which had been cut off by the floods. We also initiated doxycycline prophylaxis for all those who had been flooded in Kerala. And our postgraduates were also a part of the Uttarakhand floods, the Kashmir earthquake, and so on. So what have we learned from all this? What we have learned from all this is that epidemiologically well-designed plan studies can help in generating valuable information on the prevalent diseases and the possible solutions. So it is for us, teaching institutions, universities, to provide solutions, to find out what the local problems are, and to find solutions for that. We also work with we can't work in a silo. We work with the public health system. In Kerala, particularly, the public health system is strong as it is in Tamil Nadu. We work with them or we assist the public health services. Like I told you with the example of vaccination, or with doing, apart from the smoke-free project, we also use the self-help group members to look at the control of hypertension. And we were able to demonstrate a decrease in blood pressure by 4 to 5 millimeter of mercury, which is indeed, which is as good as any drug can do. And this has also been published, again funded by the Harvard T.H. School of Health, done by Dr. Rakesh. So it is also up to us, institutions and universities, to provide out-of-the-box solutions too. And through all this, we have learned that interventions work best. Now it is written in the textbooks. Board Committee, which was formed, the Health Survey and Development Committee of 1947, had already their focus. It is like a timeless document with the focus on primary and primordial care. And that still remains, and it is easier on our pocket too, particularly for a low middle income country like ours. And through this, through approaching the primordial and primary prevention, we can also address the social determinants of it. And socially, it is a win-win for us, for the students, and for the community. And it gives us a lot of joy. And it is a collaborative, multidisciplinary undertaking. And it makes good public health sense because it is easier on the pocket. Cost effectiveness is something that is, because even with the tobacco smoke-free home project, we know that it has been well established that using tobacco leads to more ischemic heart disease. It leads to more lung cancer. And the surveys over the years have shown, the Global Adult Tobacco Survey has shown that there's a decrease in smoking with a marginal decrease in indoor smoking as well. But even then, when we see for ourselves people falling like nine pins, people in this particular project, we have 30 clusters in our 15 in the intervention group and 15 in the control group. And we see deaths occurring right in front of us, not just them who may be suffering from stroke or who had a heart attack or myocardial infarction. Also, their spouses having respiratory issues or hypertension or even resulting in death. And everybody can practice public health. A doctor, a non-medical person, addressing the social determinants is equally important. And the community also has to practice public health in order for us to be successful in having healthy communities. Now, as far as medical education is concerned, because healthcare I have considered synonymous also inclusive of medical education. So this experiential learning that our students gain, it is a huge investment. And teaching them to document, teaching them to document and teaching them to do research and teaching them to find out what the local problems are and to find out what the local solutions are is very, very important. Documentation, as one of the Deputy Dean said before, is very, very important. Whatever we do, we should document. And publications. So when we document, publications should follow, ensuring quality by seeing that our instruments are good instruments and the devices that we use. So in the HemoQ that we used with the device, when we were using it in very hot environment, we saw a fluctuation in the HbA1c. So again, we should be prepared to monitor our devices for quality. And even the questionnaires that we use, we are always depending on questionnaires from the West. We should develop our own questionnaires. And the newer initiatives of NMC, the family adoption program. And in fact, I was at a meeting with the ICMR DG and the NMC chairperson, there are 60,000 postgraduate students in India, medical postgraduate students. And it has now been suggested that they take up multi-centric studies so that we can pool resources. And the information that we get is much more richer, much more better, which can be used instead of repeating these national surveys over and over again. So this was a very important suggestion that came up from that. The power is low, so I'll quickly go through this. The way forward is using technology as much as possible. India is becoming a technology hub, task shifting so that we can access more number of people and using machine learning and AI. In fact, now right from 10th, the students are having an option of undertaking artificial intelligence. Imparting skills is perhaps the way forward. And again, we shouldn't forget the team that works together. Building and nurturing the team is very, very important in order to be successful. Because human resources are perhaps the most difficult to manage. And let us teach our students to go to the people, live with them, learn from them, and to love them. Thank you. I'll just see if I can find my charger.
Sure, ma'am. Thank you, ma'am. That was a lucid presentation. You have shared your experience and enlightened the audience with various extension and outreach activities in improving the healthcare system. Once again, thank you, ma'am. Now the session is open for discussion. I request the participants to unmute yourself and ask questions.
Hello, am I audible?
Yes, sir. Yes, sir. You're audible.
Yes, this is Rajashekaran from Pharmaceutical Engineering Department, AVIT. I have a small doubt here. Just now, the word is introduced, like artificial intelligence and MI, and then how to use this concept in the medical sector. Like I saw your slides, you written that like technology, use technology under that AI and ML.
Yeah, thank you for that question.
Yes.
Artificial intelligence has a big role to play in medicine as well. X-rays can be read, X-rays or mammographies can be read with artificial intelligence, and you don't need a skilled person there, a radiologist there to read. Instead of that, AI can help us to read these mammographies or X-rays and help us to identify persons with
Okay.
with breast cancer, and so on. Even for road traffic accidents. 1 second. Hello, can you hear me?
Yes, please continue.
Yeah, so apart from that, apart from X-rays, even for a dengue screening, or even if we have HbA1cs, if it is a if we are training a health worker to do it, so reading that, whether it is a normal level or it is a high level, all that can be done with the help of AI. So
Okay.
AI is even ECGs, whether you want to predict whether the person has AST elevated MI. So that can also be done with AI.
All right. I have another doubt. Like so far, all this, whatever the data you mentioned, those are all predicted or maybe interpreted by the manual, by men, the operator, the skilled operator. Now, if you are introducing AI into that system, is it really helping human, or it's like it's reducing the job opportunity?
I don't think it is reducing the job opportunity. For example, because there are many remote parts of India which are underserved. So even if I want to diagnose diabetic retinopathy, so photographs are taken by this iPhone, which is connected, and you don't need to dilate the eye, which means the retinal pictures can be transferred through WhatsApp to a doctor who's sitting here.
Yeah.
Or if the doctor is not available, maybe it is at night or the doctor is not available, the AI can read it and say, this is the diagnosis, whether you need to go to the next higher center, or you can just control your blood sugar and stay there. So that kind of important input can be provided by AI. And I don't think it will, because anyway, people are not going to the rural area and are not working there. So these kind of machines will help us to reduce, will help in task shifting, and will help in making health services available to a larger number of people.
Okay. Thank you so much. Thank you so much.
Thank you.
Thank you, sir, and thank you, ma'am. Participants can unmute and ask if you have any doubts on this. So as we do not have further questions, we'll move on to the next session. We request all the participants to fill up the feedback form, which is posted in the chat box. No duty is more urgent than that of returning thanks. Now I request Dr. Selvam, IQAC coordinator, to deliver the vote of thanks.
Thank you, madam. On behalf of IKC BMKVMSH and a university, it is my privilege to propose vote of thanks on this occasion. First, I would like to express my sincere thanks to our respected Dean, Director IQAC of our university, Medical Superintendent, Deputy Dean, and Director Hospital Development Committee have facilitated this program a successful one. Thank you Thank you, sir and madam. My immense thanks to today's distinguished speaker, Professor Dr. Ashwati, who have graced the occasion and also enlightening with a communicable talk on the topic. So today topic, madam have given is a wonderful talk. Based on this, through all outreach and then extension activities have done by their institutions through funded projects, as like ICMR and then WHO. I hope that madam may give that ideas and suggestion in future to improve the same line of these funded projects to take our institution for furthermore is it strengthening of our extension and outreach activities to quality and concern. Thank you so much, madam. I express my humble thanks to Dr. Manivanan, Professor and HOD of Pharmacology, who have given a neat welcome address. Thank you, sir. And I extend thanks to Dr. B. Sendil Kumar, Research Coordinator of our institutions. Introduce the guest speaker. Thank you, Dr. Sendil Kumar. I extend a warm thanks to Dr. Priya K. Das for comparing the entire program. Thank you, madam. My sincere thanks to all the IQAC coordinators of the constituent colleges and schools of our university and faculties for actively participated in this program. Thank you all, and once again, thank you so much.
Thank you, sir. And I thank everyone once again for making this event a memorable one. And we request the participants to kindly fill up the feedback form.
Thank you. Thank you all.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, ma'am.
Thank you.
Thank you, madam.